So today I'm going to talk to you about Introduction to Radiation Biology. My name is Christiane Burton, and I am a diagnostic medical physicist at Boston Children's Hospital, but I'll be giving this talk at the Brigham and Women's Hospital. So this is just an outline of what I will be talking about, basically going from understanding the types of radiation to how they cause biological effect, and then how we can use this information when we're doing treatment planning. So what is radiobiology? It is the study of the action of ionizing radiation on living organisms, and the action involves physics, biology, and even some chemistry. And there are different types of ionizing radiation, like alpha particles, beta particles, neutrons, photons, protons. It also involves the energy absorbed at the atomic and molecular level, which leads to biological damage. And then there's also repair of the damage in living organisms. So there's repair mechanisms for DNA, for example. And these basic principles are used in radiation therapy with the objective to treat cancer with minimal damage to the normal tissue. So let's start off with the types of ionizing radiation. So radiation is classified into two main categories. Non-ionizing radiation, so one that cannot ionize matter, so cannot kick an electron out of the atomic shell, for example, to create an ion. And then there's ionizing radiation, which can ionize matter. And that's the one we're interested in. So there's two major categories of ionizing radiation. One is the directly ionizing radiation, which is basically due to charged particles, the Coulomb Coulomb interaction. So this involves electrons, protons, alpha particles, heavy ions, and these basically deposit their dose right away. Then there's indirect ionizing radiation, which is neutral particles, so particles that don't have a charge. And that includes photons, which can be X-rays or gamma rays, and neutrons. And basically they interact with charged particles that deposit their dose. So in my diagram down here, I have a photon coming in to the atom, and it's basically kicking the electron out, therefore ionizing the atom. So these different types of radiation interact with matter quite differently. If we go on the left here, I have an alpha particle, which is a heavy charged particle. Then I have a beta particle, which is essentially an electron. It's a lighter charged particle relative to the alpha particle. I have a photon, or a gamma ray. It's a photon. It's a light neutral particle. And then I have a heavy neutral particle, which is a neutron. So if we go back up to the alpha particle, basically what happens is when it interacts with matter, it doesn't go very far because it's a large charged particle, so the chances of it interacting with another atom in the material is a lot higher because of its size. So it will deposit its dose more readily along the way, and it will eventually get absorbed completely in the material. Alpha particles are actually so easy to stop. You can stop them with a piece of paper. And then you have a beta particle, which is an electron. And what the beta particle does is when it interacts with matter, is it can interact with another electron, and that electron can go on and deposit its dose along the way until it is completely absorbed by the medium. Or it can interact with a nucleus, and basically as it impinges on the nucleus, it will come in at an angle where it will give off a photon, as you can see here. And the energy of this photon is dependent on the angle that it interacts with the nucleus. So after it creates a photon, the electron can still go on to deposit dose and then eventually get absorbed by the medium. This photon can either go on to interact with an electron, or it can escape the medium completely, depending on its energy. And then we have a photon here, which is similar to the one I just described. So this is a gamma ray, and basically when it interacts with matter, it'll interact with an electron and basically kick it out of its shell. and that electron will interact with the material and deposit its dose completely. And this photon will be scattered, and it might go on to interact with another electron, and that electron will deposit its dose completely, and the photon actually might leave the matter. If the photon has just enough energy to kick an electron out of the K shell, a photoelectric effect will occur, and then the photon will be completely absorbed within the material. Then there's the neutron, which is a heavy neutral particle, and that'll interact with a proton as part of neutron capture, and the photon will be let off, and an electron will be absorbed. So charged particles interact strongly and ionize directly, and neutral particles interact less, ionize indirectly, and penetrate further. And so as you can see here on the right, gamma rays and X-rays are the ionizing radiation. They have the smallest wavelength, the highest frequency, and the highest photon energy. If we go down to the radio waves, the wavelengths are pretty long, and they don't have a very high frequency relative to the other two gamma rays and X-rays, and they have less energy as well. So if radiation is absorbed in biological material, ionizations and excitations occur in a pattern that depends on the type of radiation involved. So depending on how far the primary ionization events are separated in space, radiation is characterized as sparsely ionizing X-rays or densely ionizing, like alpha particles. So the sparsely ionizing, which is the low LET, is when a low amount of energy is deposited per unit length. And then densely ionizing is when you have a high amount of energy deposited per unit length, and we'll talk about that in a little bit. So heavier particles with larger charge produce higher ionization density. For a given particle type, the density of ionization decreases as the energy and velocity goes up. So this brings us to the linear energy transfer, and I pulled this definition directly from the ICRU document, International Commission on Radiation Units. So the linear energy transfer is the average energy locally imparted to the medium by a charged particle of specified energy in traversing a distance. So this is the equation for the linear energy transfer. It's the amount of energy that is transferred to the medium over a certain length. So this doesn't talk about how the energy is absorbed. This is just talking about how the energy is transferred. And the LET, as we call it, that's the acronym, is used to define the quality of ionizing radiation beam. The unit is keV per micrometer. keV is just an easier number to work with. Sometimes we deal with MeV, but keV is useful. And micrometer, just because of like the distance that we're interested in. This is different from the stopping power, and you might have heard the stopping power, which is basically the retarding force of charged particles due to the interaction with matter. That's also not an indication of how the energy is absorbed by the medium. It has more to do with the material itself. So LET is an average quantity, and is typically track averaged. So there's two ways that you can calculate the LET. The first one is track average, as I mentioned. So it's calculated by dividing the track into equal lengths and averaging the energy deposited in each length. This is good because then the track, the track remains constant, and you just have to worry about the energy. So, and this is so you can compare both different types of radiation. So here you can see that the track has been divided into equal lengths, and then basically just take the average of the energy deposited in each track. Then the energy average is calculated by dividing the track into equal energy intervals and averaging the length of the track that contains this amount of energy. So, keeping the energy the same, but then, deciding where what the track lengths should be. So it's a little bit easier to use the track average, and I understand why they use it. And just some typical LET values that are commonly used. So for a 250 kVp X-ray, the LET is about 2. And then the 1 MeV electrons, the 3 MeV X-rays, if we want to compare, is 0.3 keV per micrometer. So if we compare the 3 MeV X-rays to the 250 kVp X-rays, you can see that when the energy is higher, the X-ray it penetrates further into the medium, and it interacts less with the electrons. So the LET is going to be smaller. And if we look at a really high energy electron at 1 MeV, the LET is pretty much the same as that, so 0.25. So even though this is a charged particle and the X-ray is not, if you have a high enough energy, it also won't, the likelihood of it depositing its dose at that energy is still kind of low. And if we look at LET values for other less common radiations, so like a 14 MeV neutron, so again, large charged particle that interacts with protons, the LET is 12 keV per micrometer. And then heavy charged particles is about 100 to 200. And then you have the very low energy electrons, so 1 keV electron. The LET is about 12.3. And then for 10 keV, it's about 2.3. So the lower the energy of the electron, the lesser it will penetrate in the medium and deposit its dose more directly. And so why do we care about LET? And this is where we're getting into the biology a little bit. So if we look at a beta particle with an LET of 0.2 keV per micrometer, you can see that the number of interactions or ionizations or excitations is kind of low. And if we look at an alpha particle with an LET of 50 to 230 keV per micrometer, we can see that the chances of interaction with the DNA is quite high compared to the beta particle. So there's a higher chance that an alpha particle will interact and actually do some damage to the DNA compared to the beta particle. And the optimal LET is actually about 100 keV per micrometer in terms of producing a biological effect. And as you can see here, when you get to 100 keV per micrometer, you get a double strand break. You still get that with 200 keV per micrometer, but the 100 keV will perfectly hit the 2 strands here. So at this density of ionization, the average separation in ionizing events is equal to the diameter of DNA double helix, which causes significant double strand breaks. And these double strand breaks are the basis of most biological effects. So you can see here, this is DNA that's intact, not damaged. You can get a single strand break here, but if you have a single strand break, the DNA can basically repair itself because it has a template. So it knows that the adenine needs to go here. You could also get another strand break over here, but again, the DNA can repair that because it has a template. And then you can have a double strand break, like I described before. And these are believed to be the most important lesions produced in chromosomes by radiation. So the interaction of double strand breaks can result in cell-killing carcinogenesis or mutation. And so this brings us to the cell survival curves. These are very useful, and I'll be talking about them. I'll be using them throughout the talk. Basically, on the right here, we're looking at the surviving fraction, which is a ratio as a function of dose. The dose can be in rads, which are older units, or in gray, which are more up to date. So a cell survival curve describes the relationship between the radiation dose and the proportion of cells that survive, as you can see. So over here, what they've done is they have different assays and they put a certain number of cells in them. Then they choose different doses to radiate these cells, and they have one control where they give no dose. And basically, after they've applied radiation, they let it incubate for 1 to 2 weeks, and then they try to count how many cells have been left in the medium. And this is to determine the plating efficiency. So radiation dose, the cells will die over time. So we're just trying to keep a control here. And you just get a plating efficiency so that you can calculate that. So you just take the surviving fraction and multiply it by the plating efficiency. So if you come over here to the cell survival curve, you can see that X-rays are over here. You have 15 MeV neutrons and then alpha particles. So it requires less dose to kill off the cells for alpha particles than it does for neutrons and X-rays. In fact, if you increase the LET, then it will require less dose to kill these cells. So that makes sense because alpha rays will interact with the DNA more readily. So these cell survival curves are also presented in the form with the dose plotted on a linear scale. So this is a linear scale here, and the surviving fraction on a log scale here. And the shape of the curves basically follow this linear quadratic model that assumes that there are two components of cell killing, only two adjustable parameters. There's no final straight portion that is observed experimentally, but an adequate representation of the data up to doses used as daily fractions in clinical therapy. So you can see here that in terms of chromosomes, you get a double strand, a double break here, and then you have each a single two breaks due to two separate events here, and that's a quadratic part. And up here is this is the linear part. So two breaks due to the same event. So this brings us to relative biological effectiveness. So absorbed dose can be a poor indicator of the biological effect of radiation. It doesn't give us an assessment of the risk. So this is something that documents like ICRP 60 and 130 talk about when they factor in weights of the radiation and the tissue type. So the biological effect can depend on many factors such as type of radiation, initial energy, and type of tissue. So in these documents, the ICRP documents that I mentioned, they will try to calculate the effective dose and the equivalent dose, and they'll take into account the weight of the radiation. So an alpha particle would, they give it a weight of 20, and a photon they give it a weight of 1. So if you're exposed to alpha particles, you have a higher risk. And then they also weight the type of tissue. So lungs, for example, weight at about 0.12, and something like the thyroid weights at about 0.05, and the skin is like the least sensitive at 0.01. So lungs are the most sensitive. So for example, 1 gray of neutrons produces a greater biological effect than 1 gray of X-rays, just due to the difference in the pattern of energy deposition. The relative biological effectiveness is the ratio of biological effectiveness of one type of ionizing radiation relative to another, given the same amount of absorbed energy. If you don't have a sense of what this means yet, I'm going to show you a graph in the next slide. So the RBE is an empirical value, and it varies with the type of ionizing radiation and the energies involved, and the biological effects such as cell death and oxygen tension, and this is something I'm going to mention later on in the talk. So RBE compares the test radiation R, so R meaning neutrons, alpha particles, even photons at different energies, with 250 kV X-rays, and it's defined as RBE equal to the dose of 250 kV to DR. So DR is the absorbed dose of radiation of type R that causes the same amount of biological damage as D250 kV. So what does this look like on a cell survival curve? So if we look at this curve here, the surviving fraction is a function of dose. If we're comparing neutrons and X-rays, basically we're looking at the same surviving fraction and we're just taking the ratio of these two doses, and this will give you the relative biological effectiveness. So over here it'd be 5.6, and then as you increase the dose for both neutrons and X-rays, you'll see that the relative biological effectiveness decreases. And I guess this graph over here just showed it a little bit better. So basically, for the same survival fraction, we're comparing dose X and I. So in general, the RBE increases with LAT to reach a maximum RBE of 3 to 8, and that depends on the level of cell kill at an LAT of 100 keV per micrometer, and then decreases because of the energy overkill. So if we look at the RBE here, the RBE graph, and we look at how it varies with LAT, so just ignore the OER for now and focus on the RBE. As the RBE will increase with LAT, and basically it will peak at about 100 keV per micrometer, and then it will start to decrease because of energy overkill. And if you recall, the optimal LAT when it comes to DNA damage is 100 keV per micrometer. So this is the classic paradigm of radiation injury, and there's a bit of a time frame down here as to when, just to give you an idea of when these events occur. So if we start over here at ionizing radiation, we can go down this path first. So excitations can lead to heat. Heat is uncomfortable, but there's not a large amount of damage there in terms of DNA damage. We can have ionizations. So this includes free radical formation, which I'm going to speak about soon. But we also have chemical repair. So ions can recombine with each other. And this occurs in the span of seconds, on the order of seconds. The ionizations can lead to DNA damage, and the DNA can repair itself. There's enzymatic DNA repair, and all this can occur within minutes or hours. The DNA damage can go on to produce cell death, so you can have an early acute effect with like radiation sickness, which is basically like having diarrhea or vomiting. And this can occur in a span of days. You can have developmental effects in your fetus, which can occur in the span of weeks, and then late effects, which can occur in the span of months. These are more like these are effects that actually that you don't know you have until a little bit later. More on the deterministic side of things. And then you have a DNA mutation. So you go down like 2 lines here. There's the germ line, which are your germ cells or your sex cells. And this, damage to the germ line will have heritable effects, which will affect generations. So your offspring, their offspring. And then there's also somatic cells, which, if there's DNA mutation, this can lead to malignant transformation, and then eventually lead to cancer. And typically cancer has a latency period of years or even decades. So this is kind of like how it occurs, how the biological effects will occur. So start off with incident radiation. The radiation is absorbed, and excitation or ionization will occur. So we've talked about these 3 already. Then there will be possibly free radical formation, most likely. There's also direct effects, and we're going to talk about that next. And that'll lead to breakage of chemical bonds, and then that will lead to biological effects. So just to give you some numbers first, biological systems are very sensitive to radiation. Absorption of 4 gray in water produces the rise in temperature of 10 to the power minus 3 degrees Celsius. So it's about 67 calories in a 70 kilogram person. The whole body dose of 4 gray given to a human is lethal in 50% of cases. So that's the LD, the lethal dose 50. The potency of radiation is in its concentration and the damage done to the genetic material of each cell. That shouldn't be surprising given the information in this talk. The biological effect is expressed in cell killing or cell transformation, so carcinogenesis and mutations. The primary target of radiation is DNA, so suffering breaks in chemical bonds. And depending on the extent of the damage, it can be repaired through several repair mechanisms in place in a living organism. So let's focus on the cell first. All living entities are made up of protoplasm, inorganic and organic compounds dissolved in water. The cell is the smallest unit of protoplasm capable of independent existence. So it's the basic microscopic unit of all cell membrane, which is around the cell. And then within the cell, you have the protoplasm, which is all living materials within the cell. And that comprises of the nucleus, which is what we're interested in, and the cytoplasm, which is the liquid that surrounds the nucleus. The type of cell that we're talking about, so we have germline, germ cells, which is basically the sperm and the ovum. Anything else is somatic cells. So, here I'm going from fertilization to Jim Smith. But Jim Smith has his own germ cells, so he's got his own sperm cells. So the effects of radiation on human population can be classified as either somatic or genetic, which is why that matters. So somatic effects are harm that exposed individuals suffer during their lifetime, such as radiation-induced cancers like carcinogenesis, sterility, opacification of the eye lens, etc. Genetic or hereditary effects are radiation-induced mutations to an individual's genes and DNA that can contribute to the birth or defective descendants. So the cell nucleus contains a sensitive component for radiation-induced cell killing, not in the cytoplasm. When directly ionizing radiation is absorbed in biological material, damage to the cell may occur in one or two mechanisms. So there can be direct or indirect. Direct is a little bit more easy to explain. So when a photon comes in, it will interact with an electron, and that electron will interact with the DNA. Alternatively, an electron can just come in and interact with from the outside and interact with the DNA. So this interaction that the photon goes through with the electron is a form of like a Coulomb interaction. And so this leads to it leads to a chain of physical and chemical events that eventually produce the biological damage, and is a dominant process in the interaction of high LET particles such as neutrons or alpha particles with biological material. Indirect action is when a photon comes in, interacts with an electron, and that electron interacts with the water, and it forms free radicals. And then through diffusion, those free radicals will interact with the biological material. So the cell is composed of 80% of water, which is why it's possible. Indirect action can also be modified by chemical sensitizers or radiation protectors, and that's something I'm not going to talk about in this talk. So just be aware that they exist. So for indirect action, these are the basic radiochemical reactions that occur in the water. So basically, the water, after an electron interacts with it, the water will go through this, this chain here. It can go down different paths, but basically it ends up, with these types of molecules. And this one here, the hydrolyzed electron and the hydrogen and the hydroxy molecule, these are highly reactive species. And so about 2/3 of biological damage by low LET radiation, so sparsely ionizing radiations, is due to indirect action, and 1/3 is due to direct action. This is just kind of a time frame of all the events that occur. So there's the physics, the chemistry, and the biology. So you go from incident X-ray photon to fast electron or positron. So that's physical. You go from the fast electron or positron to the ion radical. That's also physical. You go to ion radical, from ion radical to free radical. That's chemistry. Free radical to breakage of bonds, also chemistry. And then breakage of bonds to biological effect is biology, basically. So the physics of this process is on the order of like 10 to the minus 15 seconds. The ion radicals have a lifetime of the order of 10 to the minus 10 seconds. The free radicals have a lifetime of the order of 10 to the minus 5 seconds. And the step between the breakage of bonds and biological effect can take hours, days, or even years, or even decades. The chromosome is basically, DNA molecules carry the genetic information. So chromosome is an organized structure of DNA, and DNA-bound proteins serve to package the DNA and control its function. Chromosomes are located mostly in the cell nucleus, and there's some amount in the mitochondria. But this is basically, the structure of it down here. This is what it looks like. And you can get a translocation, which is basically when these two parts here of the chromosome break off, and then they kind of reconnect because they're sticky parts, but they don't connect with the right chromosome. The chromosome can just have a deletion, so all this DNA material here is just gone. There can also be an inversion, so the chromosome, it kind of breaks apart here and inverts. You can also have an insertion where some foreign material gets inserted into the chromosome. You can also have a ring chromosome, which is basically like when the top part here is cut off and then the bottom part is cut off, and then they kind of form a ring with each other. You also have the isochromosome and then the derivative chromosome. So it's important to note that the cell actually goes through a lot of checkpoints first. So this is why we have to be aware of the cell cycle. You can see here, this is the cell cycle. So there's an interphase period, and then there's a mitosis where the cells actually divide, and then there's cytokinesis when there's cell separation. So the G1 phase, right here, is when the cell increases in size and the cellular contents duplicate, excluding the chromosomes. Everything else is duplicated. Then it goes to the S phase. So this is where DNA replication occurs. So each of the 46 chromosomes is duplicated by the cell. Then it gets over here to the G2 phase. The cell prepares for cell division. So the cell will double check the duplicated chromosomes for error, making any needed repairs. And then the M phase, it's when mitosis occurs, followed by cytokinesis, which is cell separation, so the formation of two identical daughter cells. And each of these phases, which we'll see later why this is important, each of these phases have different sensitivities to radiation. So the mitosis phase is actually the most sensitive, and the late S phase is the most radio resistant. And it kind of goes M, G2, G1, S phase, and then the S phase is broken into beginning and end, and where the end phase is more radio resistant. So, and we think it's more radio resistant because of the homologous recombination between sister chromatids to repair damage. So if there's some sort of repair mechanism, it'll make it harder to destroy the DNA or the chromosome material. And just to give you an idea of the timing, so the cell cycle, which is the time between successive divisions or mitosis, it's different in mammalian cells. It's on the order of 10 to 20 hours, and there's a little bit of a discrepancy for a reason. So the S phase is usually in the range of 6 to 8 hours. The M phase is usually less than an hour, and the G2 phase is in the range of 2 to 4 hours. And then you have the G1 phase, and this is the most variable phase. It can be in the range of 1 to 8 hours depending on the type of cell. And during the cell cycle, this cell will go through a lot of checkpoints just to make sure that it's ready for division. You can see all these like cyclin, these molecular genes called cyclin. So the cell cycle progression is controlled by a family of molecular checkpoint genes. Their function is to ensure the correct order of cell cycle events. The genes involved in radiation effects halt cells in G2 so that an inventory of chromosome damage can be taken and repair initiated and completed before the mitosis is attempted. Cells that lack checkpoint genes are sensitive to radiation-induced cell killing and carcinogenesis. So, very important. And there's also different kinds of mechanisms for cell death, just in case the cell decides that it's not good for division. So there's mitotic death, which is when the cells die attempting to divide. And that's primarily because of the asymmetric chromosome aberrations, and that's the most common mechanism. The other way is apoptosis. This is something I haven't mentioned yet, but it's basically programmed cell death in cell separation in apoptotic bodies. Last one is bystander effect. This one is interesting because the cell, once it's affected, it actually warns other cells. So it releases the cytotoxic molecules to warn its neighboring cells that it's been affected, and then they also decide what they need to do, either commit apoptosis or continue to live on. This brings us to the concept of fractionation and why we use radiobiology, or how we use radiobiology in radiation therapy. So radiation therapy has traditionally been a fractionated treatment course spread over several weeks. It does take advantage of the differential repair abilities of normal tissue and malignant tissue. So it's important to note that we're not just dealing with tumor cells here, but we're dealing with normal tissue. And so here we have a cell survival curve again, so surviving fraction as a function of dose, and this is typically what I've been showing throughout the talk, this single dose, so just one hit basically, and just ramp up the dose. Now if we split it into two, we'll see here that you have a split dose. So the surviving fraction, as you can see, is a lot higher compared to the single dose. But there is a reason for that, and we'll get to that. And just remember, we're not just dealing with the tumor cells, we're dealing with the normal tissue. So the concept of fractionation was first discovered by a guy named Rigaud, and he did this experiment on a French ram. So a single dose of radiation was sufficient to sterilize a ram. They needed to give it to this area here. But doing that would also cause significant skin toxicity. So what he decided to do is give the same dose, but delivered over several fractions. And the ram was sterilized, and there was no skin toxicity. And this is just because of fractionation. So in the 1920s to 1930s, Rigaud, he extended the treatment to uterine cancer, and it improved the outcomes. And then Coutal, in the 1930s, he applied this fractionated treatment for the head and neck cancer, and reduced the toxicity with better outcomes. So you've probably seen some of the alpha and beta, these variables on the graphs before. So I'll just talk a little bit about it. So this is the linear quadratic model, and this is the equation that is used for the cell survival curve. So the cell survival is dependent on the dose, but it's also dependent on these variables called alpha and beta. And basically alpha describes the linear part, and beta describes more the quadratic part. And the ratio of alpha to beta gives the dose at which the linear and quadratic components of the cell killing are equal. So using alpha and beta ratios to generate treatment schedules, employing different size doses per fraction in order to match the probability of causing a tissue injury. So the value of the ratio alpha beta tends to be larger for early responding tissues and tumors. So a dose of 10 gray would be sufficient, and it's lower for late responding tissues, so a dose of 2 gray typically. So these different cell lines, different tissues and tumors have different alpha beta ratio values. So alpha beta of a particular tumor or tissue defines the dose of radiation at which the number of cells killed by a single hit equals the number of cells killed by 2 hits. So if you recall, this is a single hit here, this is the linear part, and then you have a double hit here, and this is the quadratic part. So a high alpha beta ratio is for most tumors, and early responding normal tissue. And then late responding tissues, like some tumors like the prostate, have low alpha beta ratios, so you can see that here as well. They're 2 to 10 gray, and then for late responding tissues, that ratio can range from 2 to 5 gray. So fractionation has a profound effect on cell survival curves for low LET radiation, and some for high LET. You can see that the low LET here has more of the shape that we're typically used to. The high LET just seems to have like a downward slope here, like a very linear slope. The main objective clinically is sparing of normal tissue by giving it time to repair sublethal damage. And typically normal tissue repair mechanisms are much more effective than those of cancer cells. We can also use this to calculate the biological equivalent dose. So that will indicate quantitatively the biological effect of any radiotherapy treatment, which will take into account changes in dose per fraction or dose rate, total dose, and the new factor overall time. So it'll actually measure the true biological dose by taking into account the number of fractions and the dose per fraction. So just as an example, I mean this is the equation, but just as an example, if you want to give 72 gray, that's what you prescribe, and you want to do 1.8 gray with 40 fractions, and you want to put that into this equation. For late responding tissues, for example, you could use an alpha beta ratio of 3, and you'll find that your BED will be 115.2 gray over 40 fractions. And then for late responding tissue, the dose that you might give is 84. The BED may be 84. That's over 40 fractions. This is for early responding tissue. So this is just a useful way to calculate the BED. And that brings us to the concept of the 4 R's. So we know that fractionation of radiation dose typically produces better tumor control for a given level of normal tissue toxicity than a single large dose. The radiobiological basis for fractionation actually depends on the 4 R's. So repair, reassortment, repopulation, and reoxygenation. So repair of sublethal damage to cells between fractions caused by radiation. And this is both for tumor and normal tissue. Then you have reassortment of cells into radiosensitive phases of the cycle, which we talked about, and we'll kind of show how that factors into fractionation. There's repopulation or regrowth of cells between fractions, more useful for the normal tissue, and reoxygenation of hypoxic cells to make them more sensitive to radiation. And this is more useful for the tumor cells. So there's a few repair mechanisms, that take effect, for both the tumor and the normal tissue. So you want to repair. There's repair proteins. There's different types. You want to repair deficient cells that are exquisitely sensitive to ionizing radiation, and the differential repair abilities will affect the alpha beta ratio. So, and there's different repair mechanisms at different cycles here, as you can see. Repopulation, so cells repopulate between each fraction of radiation. The differential repopulation will affect the survival curve. So if you just focus on this part of the curve, this is a surviving fraction, and this is the time. Basically, over time, I guess there's 2 events here where you radiate the cells, but if you leave the cells alone, eventually they will proliferate or repopulate. So there's just see a growth here in survival curve. And then there's reassortment. So I talked about how the different phases of the cell cycle would respond to radiation, where mitosis would be the most radiosensitive, and then the S phase, particularly the end of the S phase, would be the most radioresistant. So here, say you radiate the cell and then you wait, and you get to this point here, the cells have had enough time to kind of recycle. So down here, you may have, killed a bunch of cells, and maybe the ones that are left are completely in S phase. So these cells will get into probably either the M or G1 phase. They'll get out of that S phase, and if you hit them with radiation again, the survival fraction will decrease. And then if you give it enough time again, they will repopulate. The flat line is just to indicate if the cells were non-cyclic, but they always are. Then there's reoxygenation, and this one requires a little bit of explanation. So you have the oxygen effect, which is the presence or absence of molecular oxygen within a cell that will influence the biological effect of radiation. So the oxygen enhancement ratio, the OER, is the ratio of doses without and with oxygen, so hypoxic versus well-oxygenated cells, to produce the same biological effect. So the OER is equal to the dose to produce a given effect without oxygen over the dose to produce the same effect with oxygen. So if we look at the surviving fraction here, survival curve, sorry. This is surviving fraction as a function of dose again. We have got two curves here. One is the aerobic, so this is the oxygenated cells, and then you have the anoxic, which is the hypoxic or non-oxygenated cells. So the OER will change over time. You can see how it divides between anoxic and aerobic. So oxygen makes the damage produced by the free radicals permanent. That's something that it does. The damage can be repaired in the absence of oxygen. So an oxygen enhancement ratio is equal to 3 for X-rays, 1.6 for neutrons, and only 1 for alpha particles. So having an OER around 1 is pretty good. It's ideal. And as luck would have it, the OER decreases as the LET increases and approaches an OER of 1 for an LET of about 150 kV per micrometer. So now if we're looking at the OER graph here, for low LET, the OER is quite high, but as the LET increases, the OER will start to decrease, which is good. And it kind of overlaps with the 100 kV per micrometer. So again, that's lucky. And if you recall, that's the optimal, the LET of 100 kV per micrometer is optimal for double strand breaks. And then here, if we're looking at tumor reoxygenation, you have the blood vessel, oxygenated blood vessel with transporting oxygen, and oxygen can diffuse at only about 70 millimeters from the blood vessel. So if you have a necrotic cell up here, this is where there's no oxygen up here, and then you have your tumor here, and it's about at 70 millimeters. I think that should be, sorry, not 70 millimeters, it should be 70 micrometers. So the solid tumors often outgrow their blood supply, and they will become hypoxic, and these cells not receiving oxygen and nutrients eventually become necrotic. So the reason why we need oxygenation, reoxygenation, is because if we're going to fractionate, basically the tumor contains a mixture of aerated and hypoxic cells. So a dose of X-rays kills a greater proportion of aerated cells than hypoxic cells. So if you have your tumor here, well, this whole thing is your tumor. The aerated cells are on the outside, so oxygen can actually reach them. Hypoxic are on the inside. Irradiate the cell or the tumor. It'll interact with the aerated cells, and then it'll remove them, and basically you'll be stuck with the hypoxic cells immediately after radiation. But then the reoxygenation will occur, and you'll see that this tumor will have oxygenated cells on its surface again. So if you hit it with radiation, you'll kill those cells, and this tumor will eventually get smaller and smaller. So fractionation actually allows the tumor to reoxygenate, and it has a great influence on tumor response. So these are just some of the references that I used. One popular one is from Eric Hall, Radiobiology for Radiologists. Another book is Johns and Cunningham, The Physics of Radiology. I also use the Progorshak book for watching this video. Please leave a comment below if you have a question, and I'll try to get back to you as soon as possible. And please feel free to subscribe to my channel. Alright, thank you.